we should have a great understanding of it. And just to also back up a little bit with the dermal puncture, you see it says use of a sharp device to remove a small specimen of capillary blood. So do you see what I say about capillary puncture and dermal puncture is the same? Capillary is just the type of blood, where we're getting it from. And then dermal puncture is just the skin, puncturing the skin. Dermal means skin. But when we puncture the skin and blood come out, that's capillary blood. For example, I think of the craziest stuff. Let's just say we putting a hole in our belt, right? And we're using whatever knife or whatever sharp object we have at home. Let's just say that we mistakenly actually stick ourselves with that knife and blood start coming out. That's capillary blood. Now, depending on how big that hole was, a lot of blood, more blood than what we saw may come out, but it's still capillary blood because it's you didn't stick a vein or artery for that blood to come out. The skin just was punctured with that knife. Okay, so dermal means skin. Capillary is just the blood vessel, the type of blood vessel that the blood is coming from, which is the capillary blood. Okay, so let me move forward. Next that I have in line, which is microbiology. We talked about it briefly. So when we talk about the blood culture tubes that technically come in the order of draw first, but remember, not everyone will have order for blood cultures, which is accompanied by 2 bottles always. But those will go to the microbiology lab. Anything that you hear that goes to the microbiology lab, which is a culture, that's because the doctor knows that the patient has some type of infection and the doctor needs to know what it is and what antibiotics to help, right? We talked about that even with the urine culture in the gray stopper for the urine tube that says urine for culture CNS. That's going to microbiology too, because the doctor knows that the patient has urine, some type of infection in the urine, but he needs to know what it is. Okay. So with that being said, microbiology is the study of one cell organisms, which is microorganisms that are usually visible only under microscope. The main focus is bacteria. So this is the point that I wanted to get to. Any type of culture is trying to figure out what name bacteria is in it. It's in the specimen. So you send the urine off, you send the blood cultures off. If they tell you to cough sputum up or mucus up in a cup and take it for culture and take it to microbiology, obviously it's bacteria in all of those. The doctor just needs to know what's the name of it and what antibiotic that's going to help that particular bacteria. Okay, so with that being said, if you were to see anywhere on your quizzes or on your exam, anything dealing with culture is trying to determine what the name of the bacteria is. Okay, trying to see what bacteria the patient has. Okay, but it only can be determined from a culture, and the culture goes to the lab, but it goes to the microbiology part of the lab, if that makes sense. Okay. All right. So I want to move forward, which is going to be on the next page. I'm skipping over some things. HIV. I know we all know how to read, so that's how come I'm not going over everything, but I'm going over the most particular that I know you're going to see. I didn't want to go over HIPAA, but HIPAA is very important for you to know what it is, so that's how come I briefly went over it again. But when we turn our page over, next in the term vocabulary, I want us to be familiar with the word negligence. Negligence is an intentional or unintentional error or wrongdoing, meaning that either you did it on purpose or you did it on mistake. Even though you did it on mistake, things can still be labeled negligence. Okay, so we just have to know the difference between the two. So for example, let me give you an example dealing in the phlebotomy world. So if you do a venipuncture and you actually stab the patient pretty hard with your venipuncture injection, that is considered, you stab the patient hard with your venipuncture procedure and until a bruise came about. Rather it was a hematoma or not, a bruise came about. So would you say that that was done intentional or unintentional? So technically, the way that you're learning in my class, I'm not telling you to stab a patient with the needle at all. So with that being said, I hope that everyone is an adult to know that that's a form of negligence done on purpose. Okay. So we want to be sure that we don't do it on purpose. Okay. So a form of unintentional, but it was still considered negligence, is where you actually did the venipuncture just as you needed to do it. You did the technique right, but for whatever reason, you went in the vein a little bit too much, or you bypassed the vein and now a hematoma is coming, which it is developing a bruise with blood underneath that tissue. Okay, so now it's a form of negligence, but it was a mistake. Okay, but that's how come we teach that the moment that you see a bruise or the skin is rising due to blood accumulating in the tissue, hurry up, pop that tourniquet, take the needle out, hurry up and apply that firm pressure, because applying that firm pressure is not only helping the blood to stop, but it's also decreasing the hematoma from growing and to possibly just putting it to an end. Okay, so just be mindful that we can be negligent, you know, with on a mistake. Okay, now can you get sued for things like that? I mean, only if the patient makes a big deal out of it, and not necessarily be sued. They can file a complaint on you, but just a forming a hematoma happens all the time. It happens all the time. So no one can actually sue you for a hematoma or a bruise on their arm. I'm sure, I think we've talked about it already. Some of us have had bruises before from previous blood work. You know, I mean, you know, they didn't get sued, but if you was to go in that patient's arm in a stabbing way and they make a complaint and don't give up, and then you had a bruise here, then by some way, form, or fashion, they can figure out a way to prove a case. Okay, so we just gently using our empathy for our patients. Okay, so I just want you to kind of realize the difference with negligence, that you can actually be negligent but not mean to do it, but you can also show a form of negligence and did it on purpose. Okay, so just be mindful with that. Next in line, the word is pronounced nosocomial infection. This is an infection that is acquired while in a hospital or medical setting. So in Ebonics way, or just leveling it down a little bit, you didn't go in with no infection, but you've been in a hospital for about 5 days, 7 days. Now all of a sudden you have an infection. So that is called a nosocomial infection that you got from the hospital or from being in the clinic all, you know, too long today. For example, it could have been a simple, when COVID was out, you at your regular doctor's appointment, but someone with COVID that may not even know they have COVID. You don't have no symptoms, you don't have no COVID, but for whatever reason, you're leaving out the office with COVID. That's a little example of nosocomial infection. But these happen more than you ever know. That's why, as healthcare professionals, we need to make sure that we wash our hands before and after each patient. We clean the area that we're doing our punctures on, our venipunctures on. We want to be sure that if we do work in the hospital and we get a patient that it says contact isolation or any type of isolation, we want to be sure to use all our personal protective equipment, because even as a professional at work, you perfectly fine, but then you can bring those germs home, or you catch it yourself and bring them home to your family. See, okay. So now, Miss Ashley, you know exactly, because of personal dealing with things, you may not have known before today what that meant, but that's what that means, a nosocomial infection. So just to share real quick, you know, Miss Ashley was in the hospital and she had an example of going into the hospital with not an infection, but then later on while in the hospital, she had an infection. That is a prime example of a nosocomial infection. If you get this version of the national exam, be familiar with that because you may be one of the ones that see this vocabulary term. Okay, nosocomial infection. All right, uh, let's move on. Right underneath there's OSHA, which we talked about OSHA. We was quizzed on OSHA with the first quiz, but you will see OSHA again. So remember, whatever you're going to use for your note sheet, if you're going to have a hard time remembering these abbreviations and what they stand for, keep that in mind. You know, however, how small you write, that's up to you. But remember that OSHA stands for Occupational Safety and Health Administration. OSHA. And it's a federal body responsible for preventing or minimizing employee injuries and exposure to harmful agents. Okay. So don't get OSHA, you know, confused with the CDC because the CDC is for all of us in the whole world. Okay. They for all of us in everywhere as far as if a germ or a disease come out, they need to catch it. They need to figure out where it came from. They need to figure out how to prevent it, how to stop it. That's what CDC. But OSHA, in other words, is for us medical workers. They're the ones that the organization that protect us to with the hopes to minimize any employee injuries while we're at work. Okay. So remember the difference. PPE, we kind of briefly went over that. When I do CPR, we are going to do a segment on PPE because if you get the versions, because there's several versions of the national exam, that you need to know in what order to put on the equipment and what order to take it off. So our very last face-to-face day, I will show that and demonstrate that, okay, with all the PPE. PPE, protective coverings such as gloves, goggles, gowns, and masks that are worn to minimize exposure to blood and body fluid, required by OSHA to be worn when handling body fluids. Okay, so personal protective equipment stands for PPE. That is what we're going to use to protect ourselves from any bodily fluids that could be contaminated. Remember, we're already using standard universal precautions on everybody, which is typically gloves. But then if a patient is known to have COVID, if a patient is known to have any type of infection with their urine or with their blood, now it goes from wearing not only just gloves, we have to put on a gown, we have to put on a mask, we have to put on goggles in case something splashes on us. We're being put in a situation where something, urine can splash. Well, we have on goggles to protect our eyes. Okay, so that's exactly what personal protective equipment is gonna it is. But I'll go over later and show you a video of how to put all, what order to put all that on, and what order does all of that come off, because it's a such thing. Okay. Now I want to jump down. I went over point of, we know what phlebotomist is, we know what phlebotomy is. Okay. I told you about point of care testing. Either your test is going to say point of care testing spelled out, or it's going to say POCT. So be familiar with, you know, both point of care testing versus the abbreviation for it. And I've already explained to you guys, point of care testing is tests performed at the patient's bedside or work area using a portable instrument. That means that when it is performed at the bedside, we get the results back rapidly. Okay, with up to 15 minutes. For example, when we dipped the urine, we did the capillary puncture to check our blood sugars. I know it was wrong. I never did check bring it with me. But we did the capillary punctures to check our blood sugars. All of that was a type of result. So just remember point of care testing. Also with point of care testing, don't forget, all point of care testing need to do the control solution, okay? To make sure we don't have a defective strip with our equipment. Remember, we did that over the weekend. We have to always, every day that it's in use, we have to do the quality controls. And every time we open up a new box of strips, even if it's in the same day, and we did quality controls this morning, I ran out of strips. Now I have to open up a brand new box. Well, I need to do those quality controls again. Okay. Be aware that is, you're going to be tested on that. And literally, straight and simple. How I'm explaining it is straight and simple. If you remember that and you see the question, then you're going to know, like, oh, I'm supposed to test this every day this machine is in use. So if you get any multiple choice answers that say any otherwise, hopefully you'll know, no, I'm supposed to test this every day. Okay. So just be mindful of point of care testing along with the quality controls that we have to do with those. There goes standard precaution again. Standard precautions, infection control guidelines issued by the CDC to decrease exposure to potentially infectious substances in an acute area. So standard precautions, we can't trust no one. So we wear gloves with everything, okay? Toxicology. I'm going to talk about toxicology. I'm going to show, it's going to be a part of the special collection video. If anybody, we've already seen microbiology, and then we're seeing toxicology. The suffix, meaning the ending of the word, ology, OLOGY. Just a little simple breakdown. You know, I know we're not in nursing school, but just to give you an insight, if you see any word that ends in ology, basically it just means the study of what the first part of the word is. So that means that we have people that specialize and study certain things. So as far as microbiology, it's the study of microorganisms. It's the study of germs. So we have a department that people in the lab specialize in the study of germs, okay? Toxicology, the study of toxins, anything that is harmful to our body. For example, people do drug overdose, right? That it was toxins to their body. That's why it's even called overdose. They took too many drugs, okay? Alcohol poisoning. They drank alcohol so much to where it was toxin to their body, and now they have alcohol poisoning. That's what toxins is. Anything that is too much for the body to handle, create a toxin. Okay. So with that being said, as phlebotomists, you will get orders from the doctor, alcohol testing, drug testing, all of that just will tell your brain like, oh, you know, the doctor trying to see if this patient has too much alcohol or too much drugs in their system. Okay. But I did want to break down ology because you will see certain words with the ending of ology. And even way past this course, once you get into real life and you start working, and anything ending in ology is the study of. For example, if any of you have to take a loved one to see a heart doctor, or if you've seen a heart doctor yourself, cardio means heart. Cardiology means the study of the heart. So that doctor specializes in the study of the heart. So don't just go to your regular doctor. You want to go to somebody, if you having heart problems, you want to go to somebody that is all he or she doing is studying the heart so they can better be suitable for me. So if you're interested in learning about toxins, then toxicology, that is a person that is only studying toxins. Microbiology, that is a person that is only studying germs. So that's why these things go to the microbiology department for culture, because now we know that they have a germ, but the microbiology department is going to tell us what kind of germ it is, because all that department is doing is studying germs. Okay? If that makes sense to you. Just let me know if it don't. So I just wanted to bring that up because I'm going to quiz you on that because it is important to know. I don't want you to be like, oh my God, what is all of these ologies? You know, when you get out in the real world, all it means is the study of. And 10 times out of 10, whatever the first part of the word is what they study. So toxicology is the study of toxins. Okay. Detection and study of agents that are harmful to the body, which is toxins. So too much, it can harm the body. Okay. So urinalysis, I don't really have that highlighted, but hopefully you all familiar with that. We did that over the weekend. We dipped urine. We called it a urine dipstick because we dipped it ourselves. It was a point of care testing, but in other words, it was a urinalysis. We was doing a urinalysis right there in the lab, and per our own eyes, we was looking at the dipstick to see if a patient had a urinary tract infection. Okay, so just be mindful of that. Do I have any questions, ladies? Throw this dry. That's why. All right. Now, next in the agenda, 720. Okay. What I want you to do is get your go to the other pages, turn to the other pages, the ones that say, oh, you can't see it. The ones that say additional considerations. And on the first one, it says to prevent a hematoma. And then the second page is additional considerations, and it says page 2. Okay, so let me go ahead and move forward. Now, all of these, I call it the H's. You will see them all, okay? So I'm going to explain, I'm going to quiz you on it on the medical terminology quiz that I'm going to send you by morning. But you're going to see these on the national exam. I think all versions of the national exam have the H words, okay? And you're probably like, H word? Well, let me go ahead and move forward. So first of the H's, hematoma, Hematoma, which I've already talked about it in so many words. And for this particular statement, it says how to prevent a hematoma. But first, we need to know what a hematoma is. A hematoma is a collection of blood in the tissue. In other words, it creates a bruise to where it could be purple, blue, or red because it's nothing but blood sitting underneath the tissue. So in other words, we can say a blood clot, okay? That's a hematoma. That if we go too much in the vein or we went through the vein, it can start developing a hematoma and it can develop right in front of your eyes. So as soon as you may see a bruise or the skin start to lift, pop the tourniquet, take the needle out, apply pressure, like I said before, because you saw it about to start. And if you do just like that, it won't even, it won't develop anymore because you're applying pressure. Okay. So with that being said, a hematoma is a collection of blood in the tissue, which is basically a blood clot, which is why most skins make a bruise, because if it's a collection of blood, then that's where the bruise is coming from. Okay. And it doesn't have to be you're doing a venipuncture, from this moment on, if someone falls and creates a knot, so to speak, underneath the skin, and it starts to turn purple, bluish in color, or pink, depending on somebody's skin tone, you could be like, oh, that's kind of like a hematoma. It's a bunch of blood underneath there. Okay, so we just want to apply pressure. Now, what do we need to do to prevent hematomas? So what we need to do is puncture only the uppermost wall of the vein, and that's what we did when we was practicing on a mannequin. And for those of us that did do our live sticks on each other's already, when we stick the needle in the vein, remember bevel is always up. We're sticking the uppermost part of the vein. We're not going down, for example, like Stajan. Ooh, did I say it right? With no problem, it just rolled off my tongue. Like in the beginning when Stajan was putting her needle in and she was kind of bending the needle was bending because it's kind of flexible. Well, she could have been also sticking the lower part of the vein. We want to be at the top or the uppermost surface of the vein. So in other words, if we're too deep in the vein, it can cause a hematoma. So when we do our sticks, we just want to stick the needle, as I tell you all the time. When you see the vein and you're comfortable with what you're doing, you're just going right above that needle in a 15 to 30 degree angle, going right on top of it. You're not going deep in the arm. You're just going right in the vein. Okay, right there. So we want to stick the uppermost wall of the vein. We want to remove the tourniquet before removing the needle. So as we were doing our techniques, if you notice that every time we did our venipuncture, I tell you, pop the tourniquet and then remove the needle, okay? Because sometimes if you remove the needle first and the tourniquet is still squeezing the arm, then blood can start coming out and then a hematoma can start forming. You can start seeing a knot or a ball starting to form. So we always want to pop the tourniquet first, okay? We always want to pop the tourniquet and then remove the needle, okay? In our ways, we remove the tube, pop the tourniquet, then remove the needle. That's what we're doing in real life, okay? But you just know that before anything, let's just say, you know, your patient is starting to feel faint or starting to feel dizzy, or even a hematoma is starting to already occur. Still be sure the first thing is pop that tourniquet. That's the first thing you do. Okay, because you got to do stuff fast. But when we're literally doing the procedure and we're going in the motion that we're going, and then once our last tube is filling, we remove the tube and pop the tourniquet and then remove the needle and put the pressure with the gauze. Okay, but in an emergency is coming, forget about removing the tube. You want to hurry up and pop that tourniquet and remove the needle and get everything out the way. Okay, because obviously there's some urgent going on that you may not even be able to even send blood off or finish the venipuncture anyway. Okay, so always remember to remove the tourniquet before removing the needle. Use the major superficial veins. Don't let that confuse you, because everybody probably says superficial. That's not real veins. But in phlebotomy world and vein world, what we mean by that is you want to use the major veins. And we all know that our major veins is the medium cubical vein, the cephalic vein, and the basilic vein. Remember, although we're not drawing from the basilic until we get experienced enough, we're just going to go to the hand. But the major veins, that's what they're talking about, okay? For example, I think somebody in class was like, oh, I want to go here. And you may see some thin little blue lines. Don't mess with those. You want to go for the bigger veins that is spongy and bouncy and healthy. Yes, ma'am, Miss Nicole. Miss Ashley. Nicole must be your middle name or something. I don't know.
Yes, ma'am.
Okay. Okay. How may I help you?
Okay, so I had a question about the when you're doing the IV. So I can wait till after class for another part of it because I do have another question, but I know it might take a little longer. But one of my questions was when you're doing something with a patient who also needs like a heparin lock or something, would that ever be something that we would have to mess with? Because wouldn't that only be with an IV to do a heparin lock?
So some of the things that you're bringing up, I see is from your personal experience. Keep in mind that we're not. I mean, I know that some of us are. I know I'm a nurse, and some of us are nurses, but we're not in nursing school. We're just phlebotomists. So our typical thing is to draw blood. As a phlebotomist, you're never going to take blood from a heparin lock, from a tube, from a PICC line, from a central line at all. We're not doing that. Nurses do that. So as phlebotomists, we're simply just only drawing blood by way of venipuncture only. We're not going to mess, we're not going to get blood. So for example, let's just say if you were in the hospital, you are hard stick, you do have a central line, and for some reason the phlebotomists come to you and say, oh, you know, Ashley, I have a CBC and a CMP to draw on you. And then you'll say, oh no, I'm a heart sick. I have a central line. You know, my nurse, normally draw. Then that'll let the phlebotomist know, like, oh, I didn't even know. Like, I could have been off for days. And then I get it. No one told me you had a line. But as a phlebotomist, that is a no-no. We never mess with IVs, PICC lines, central lines, nothing. We're simply doing venipunctures ourselves if we're going to. But if you have a line and you tell your phlebotomist, oh, I haven't been getting stuck, they get it from my line, then as a phlebotomist, it's your duty to know, oh, let me turn around and go talk to this nurse. Never mess with the line because that's out of your scope of practice as a phlebotomist. Make sense?
Because every time I would tell them, because like I said, I'm a heart sick, and they quickly to go get a nurse to try to from the.
Yeah, that's why within this course, you're never going to hear me teach you how to get blood from a tube ever. We're just doing very basic venipunctures, and then we collect urine and other things, but never from a line from a patient. So even if you have a coworker a coworker that do that, that's out of the scope of practice for a phlebotomist. You never do that. Okay. Okay. All right. So good questions though, because a lot of people may have it, or you may come in contact in real life, but we never mess with anything other. If we can't stick them with a needle in their arm, then your question is, especially as a phlebotomist in the hospital, go talk to that patient's nurse. That patient nurse knows everything. So if you're unsure, back on up out of that room and go find the patient nurse for that patient. Okay. All right. So back to hematoma. Make sure the needle fully penetrates in the uppermost wall of the vein. Partial penetration may allow blood to leak out into the soft tissue surrounding the vein by way of the needle bevel. So the video that you guys saw on this weekend basically is using different terms, but what it is that if you partially go into the vein to where the bevel is halfway in and halfway out, and you're in the vein, but blood is going to come out, and from that, blood is going to come out or seep out of from the needle. A hematoma can develop from that. So we did talk about that. So that's why when we insert our needle with the bevel up, the complete bevel has to be in the vein. Okay, because remember, we go into the shaft of the needle. So with that being said, also, when we withdraw the needle, when we're done with our procedure, and the way that I instructed you guys is that once you're done, you pop the tourniquet and you're ready to take out the needle, you need to already have your gauze close to you. So as you're withdrawing the needle out of the skin, you take the gauze and you apply pressure. But I've been teaching you to make your patient apply pressure because you have other things that you're doing. But if it is an elderly person or a young child and no one is with them, then yeah, you may need to hold pressure with one hand and invert your tubes with the other hand. With experience, you're going to learn how to multitask a lot of stuff anyway. Okay. Just remember that you have to label the tubes before the patient leaves. So because they need to verify that you labeled the tube properly. So with that being said, applying that firm pressure after venipunctures is important. If you just place the gauze there, a hematoma can develop because the blood didn't even have a chance to clot, to stop bleeding yet, and you just place the gauze there. So we need to hold the pressure firmly, which we all did, okay? All right, moving on to the next H word, which is hemolysis. I think you've heard me say that this weekend. I was like, if you shake the tube too much, that blood can be hemolyzed. Of course, we can't see with our own eyes if the blood is hemolyzed. The lab tech, the lab person in the lab that's looking under the microscope will be able to say, oh, no, this blood is hemolyzed. We can't do nothing with this blood. We need another sample. So with that being said, hemolyzed means that the blood sample was destructed in such a way that the red blood cells within the blood has been destroyed. So in order to, I'm not gonna, go deep down into it, but what you need to know is that if a blood sample is hemolyzed, that's because for whatever reason, and we're gonna go over a few reasons, for whatever reason, the red blood cells in that blood sample was destroyed. So if the doctor ordered whatever test the doctor ordered, that lab technician cannot result the blood because the red blood cells has been destroyed. So that's what even hemolyzed means. You wouldn't know if the blood is hemolyzed until it went to the lab. Now, when we're inverting the tubes in a figure-8 motion after we draw the blood, that's what we're supposed to do. But if we're shaking the thing or shaking the tube and doing like this, then purposely, now, because I'm telling you and teaching you that when you vigorously shake the tubes or bounce them up and down, you can cause that blood to be hemolyzed. So if you did that, then 10 times out of 10, that blood can be hemolyzed. Can you tell by looking at it? No. Like I said, it has to be put underneath the microscope. And then that lab tech may not see the red blood cells. That's another entity of working in a lab that eventually you could be promoted to. That's a whole different training. And they'll see that there's no red blood cells. And so it can't be resulted. So just remember, hemolysis means that the red blood cells have been destroyed in that blood sample. Okay. So what we need to do to prevent that is we need to mix the tubes with the anticoagulant additive gently. So without saying all that, it's just saying that when we do the inverting, like I said, we're just doing it gently. That's all that's saying. If you do it too fast, vigorously, throw the tubes like a yo-yo ball. We're not doing all that. You can hemolyze the blood, okay? Avoid drawing the blood from a hematoma. Good one. So let's just say you did stick the patient and you getting blood, but for whatever reason, you see a knot starting to form and he or she is starting to have bruising. So obviously it's a hematoma starting to develop. You like, what the heck? What did I do? It don't matter. Go ahead and stop the process, pop the tourniquet, and go ahead and apply pressure. If you be like, oh, I just need this one last tube, and you continue to let the blood come out while the hematoma is developing, then that blood can be considered hemolyzed in that tube. Okay. But not only that, you're causing more harm to the patient and discomfort to the patient because you're continuing to let the blood come out knowing that a hematoma is forming, okay? I went through that in real life before, like years ago, and I was like, what are you doing? Like, I almost like punched the lady, because like literally you see me bruising right here, So just be mindful not to let that happen to you and not to do that to someone else. At the end of the day, we're not trying to rush. Just remember, at the end of the day, we can always collect the sample again. You trying to do whatever it is not to cause harm to the patient. You want to do safe measures, and you don't want to it's going to be hemolyzed anyway. So why are you continuing to let it float out? Okay, if that makes sense. All right, next. Avoid drawing the plunger back too forcefully if using a needle and syringe, and avoid frothing of the sample. So without being so big technical, remember I did briefly show you guys that it is a way that we can draw blood with a syringe and a needle, and that's more so just a experienced phlebotomist technique. That if you have an elderly patient and their veins are so small and so fragile, and the vacuum that we did over this weekend with the vacutainers, it's a vacuum, so it sucks the blood. It could be too much for that elderly person's vein. So, and otherwise, we would use the needle syringe method. The needle, it has a needle. The bevel is going to be always up because every needle have a bevel. And then we're going to pull the syringe back gently at our own pace, right? So if we take it and do this to the patient, of course not let the thing come out, but do this fast, then you can cause the blood to be hemolyzed. And that's just not an appropriate technique. You causing like, what is you doing, right? So we just want to gently pull back the plunger, okay, and let blood come back. We have control over it. With the vacutainers, these are vacutainers, right? So they are more like vacuums, so it sucks the blood up, okay? So be mindful not to forcefully pull the plunger back if you're gonna use that technique, the syringe method technique. Okay, then it says make sure the venipuncture site is dry. We talked about that already. When we use alcohol, we need to be sure that you let it air dry before starting your venipuncture procedure. Okay, avoid probing traumatic venipuncture. That's basically what it means. Don't just stab the needle in there. Okay, so we want to be mindful with all of this. So with that being said, this section is called hemolysis. So if the blood is hemolyzed or have hemolysis, the red blood cells has been destroyed in that sample, and you would not be able, that blood tube will not be able to be drawn. Okay, you would have to redraw the patient. So the most common reason for having hemolyzed blood that you're going to see is making sure that you invert the tube gently. Don't vigorously shake the tube. That's what you're going to see. If you do that, the blood will be hemolyzed, okay? But just know that these other choices is also a way that the blood can be hemolyzed, but moving the tube vigorously is what you would see. Okay, I'm gonna go over indwelling catheters and all that briefly when we go into special collections. But when you turn your paper over, or either do your second page where it says additional considerations, page number 2, the third to the H's is hemoconcentration. Hemoconcentration basically just means within that blood sample, we have too much concentrated blood, okay? An increased concentration of a larger molecule and formed elements in the blood may be due to several factors. So without, being discombobulated with that, what I just said, just remember that hemoconcentration just means that that sample has too much blood concentration. That's all you need to remember. Don't be focusing on large molecules, elements, and all that. Yeah, that's okay. Don't remember it in that way. Just remember hemoconcentration is too much concentration in the blood. Now, how can we avoid that blood sample having hemoconcentration? So prolonged tourniquet application. Now this paper say no more than 2 minutes. Please X that out, right? It's no more than 1 minute that we talked about over the weekend. No more than 60 seconds, which is a minute. So cross out the 2 minutes, okay? It's going to be 60 seconds or a minute. And it is on the test. I don't know what happened with this paper, but nationally in phlebotomy guidelines, it is correct, 60 seconds or a minute. So if you leave the tourniquet on too long, which is over a minute, you can cause that blood sample to have concentration in the blood. And then when it goes to the lab, they're going to say, oh, we can't draw this blood. It has too much concentration. So we need to have you redraw it. Okay. Again, you can see by your eyesight, by your human eyes, if it is hemoconcentration. The laboratory will tell you that, okay? Massaging, squeezing, or probing the site can cause the blood to have too much concentration, meaning that when we're palpating that area to get accustomed to the vein that we want to use, like we did this weekend, everybody did it perfect. We're just feeling, trying to get trying to be that we are comfortable with that area, that we know where we're going. We're not taking all our fingers and massaging in the area, tapping on here. Some phlebotomists did that back in the day, but per CLSI standards, we cannot do that. You can't tap on here. Some phlebotomists still do it. Again, like I said, in real life, Whatever you do is whatever you do. I'm not going to be over your shoulders, but I do have to teach you the appropriate way. So when we're looking at a vein and you feel a vein, you're not supposed to do this to make the vein pop out, okay? If you do that, you can cause the blood that comes out to be to have a hemoconcentration. So don't massage, screen, and probe at the site. Long-term IV therapy, of course, we don't mess with IVs, like I said before, but sometimes if you're a phlebotomist in a hospital and you already had a patient that's been there for 8 days, almost 2 weeks, and they have an IV in, and or they had an IV in and the IV was taken out, and then here you go drawing blood. Sometimes you do have to know the background of the patient and draw the arm that the IV wasn't in, if you're allowed to draw in that arm, because prolonged long-term IV use, that can also be something, with the blood. Again, how do you know? You won't know, okay? And the blood may be resulted just fine, and you go about with your day. But if you get your manager to say, oh, Mr. Brown in 303, his CBC and CMP couldn't be tested, we need to redraw them again, so you're like, oh God, it must have been hemoconcentration or something like that, right? But all you got to do is just redraw it again, or one of the other phlebotomists will just redraw it again, okay? Now, the last H word that is not on your paper, I want you to be accustomed to. Let me put up the whiteboard and kind of type it out if I can. The last H word is hemostasis. That's how you spell it. If you guys been already reviewing your study guide that I gave you with the spiral, hemostasis is in there. And it does give you the definition of it. But if you want me to break it down to you, hemostasis, yeah, I'm making sure I spell it right. Yeah. Hemostasis is the process by which blood vessels are repaired after injury. To make a long story short, when we do the venipuncture and we're done and we apply that gauze and we have to leave it on there for 3 to 5 minutes, and then we check it, and then we still, even though we don't see blood, we still apply the Band-Aid, the tape, and tell the patient to keep it on for another 10, 15 minutes, and then they can take it off. That is the blood vessels repairing itself. It's creating hemostasis. And in other words, to stop bleeding, okay? Hemostasis is just to stop the bleeding. So when we apply that gauze after the venipuncture, you could say, oh, I'm creating hemostasis. If you want to be like professional or something, all it means is that you're helping the vessels to repair itself so the bleeding can stop. Hemostasis, to stop bleeding. Okay, do I have any questions with that? Just for further, even though it's repairing itself, the process starts from vascular contraction as an initial reaction to injury, then to clot formation, and finally removal of the clot, then repair the injury is done. You don't have to remember all of that. That is big medical or, unnecessary for to jumble up in your mind. But what it does mean is to stop bleeding. How are you going to be tested? What I'm saying, hemostasis is to stop bleeding. Okay, that's what you're doing. Because when we apply the pressure with the gauze and we're leaving it on there firmly, it's creating a clot where it's stopping the bleed. That's why part of our preparation questions is asking the patient, are you on any medications, any blood thinners that you know? Because like we did this weekend, we would have to hold pressure a little longer because hemostasis will take a little longer because they're on blood thinners. Okay, if that makes sense. So go ahead and make sure that you write that or open up your study guide with the spiral and find it on page 7, highlight it. But to just make it easy is to stop bleeding, okay? For the bleeding to stop, let's put it that way. That's hemostasis. Okay, do I have any question? I call that the H's. Hematoma, hemolysis, hemoconcentration, hemostasis. Please know them. You're going to see all 4 of them. And what I just went over with the hopes that, you know, I wasn't talking fast, you're gonna see that. That was probably 4 questions that I just gave you, okay, in that way. Do I have any questions, ladies? 7:49. Oh, Lord, I'm talking too much. Okay, so with that being said, I don't have any questions or any hands up. So I want to go ahead and get into my video of special collections. And then I'm going to, you know, review the video and say it in my own words. Oh, before I do the video, I actually want to do something. I want to show you something. Good thing I have my curriculum that I check from time to time. Hold on. I want to show you this. If you're on your phone or tablet or something, I don't know if you can make a screenshot of this. If you need me to send you this, I can, for those that, you know, don't know. But it's very important. These are it's the anatomical positions that a patient can lie down or sit up. It's very important to know the difference. And the reason why I tell you that is because we talked this weekend over, what if your patient tells you when you ask, Miss Chopin, have you ever had any problems? You know, when they draw your blood, and I probably say, girl, yes, sometimes I feel like I got a faint. So, you know, I have to like sit down or recline a position, and then in my older days, if I look at the needle, I may want to throw up. You know, you got get patients that say all that kind of stuff. So with that being said, I do want you to be familiar with different positions. So right here with the, I'm assuming it's a lady. Yeah, I guess it's a lady. With the lady, she's laying face down, right? Face down with her face basically in the bed, you know, in other words. That's considered lying in a prone position. P-R-O-N-E. Prone. You won't see prone, but you do need to know what prone is, because when you look at the picture next to it, she's now laying face up, looking at the ceiling. That's called supine. S-U-P-I-N-E. So if a patient will tell you that, oh no, they have to lay me down on my back all the time, in medical terms, you would need to know that that's another word for supine. So you will see supine again, right? So in the multiple choice, it may give you different multiple choice. If you mark prone, it's because you don't understand what they are, okay? Prone is face down, supine is face up. So if I'm coming for my blood work and Chris is drawing my blood and I tell her, I get nervous. Sometimes I break out in sweat. I get dizzy. You know, I have to lay down when you draw my blood. You're not going to lay me on my face, is you? I hope not, right? So laying on your face is prone, but you need to tell me to lay on my back. But as a medical professional, you need to know that another term for laying on the back is supine. Okay, S-U-P-I-N-E. You're going to see it again. Now, when I go downward, you see she's laying on her side with her, she's laying on her right side with her hand behind her neck, so to speak. So the name of this position is right lateral recumbent. Again, I know we're not in nursing school, but what I want you to know is this middle word, Lateral. I want you to know what that is. So to make a long story short, I'm sure you know what that is. Right lateral, meaning what? Right side. So she's laying on her right side. So if you ever see lateral, just know that that means side. Okay, so I'm sure wherever lateral is, it's probably going to be accompanied by right or left. Like the pictures on top, one on top of another, one is right lateral, one is left lateral. Don't worry about the recumbent because that's just a position because of the hand being like this, meaning recumbent. But don't bother your minds on remembering that. But do picture in your photo memory, lateral means side. Okay, because in the medical world, a doctor may say something about, lay the patient right, left lateral, right lateral. Just know that that means side. Okay. Next, right here, you see the lady basically is sitting in a reclining position, so to speak. So you do need to understand and remember that if you ever hear the word Fowlers, Fowlers, Fowler's position. If you ever hear that, that just means in a reclining position. Okay. Will you see that again? You probably won't see that on your exam, but you will see lateral and supine. But if you have Fowlers as a choice, and it's all about reclining in a chair, just know the difference. But I don't think that it will have that for you. But supine and lateral for sure. Okay. Now this other one with her laying upside down, we learned that in nursing school. Don't worry about it. But if you just want me to go ahead and tell you what it is, it's Trendelenburg. Basically, it's just reverse. Instead of the patient foot being down, the patient head is down. That's something dealing with medical. Yes. Here you go. Thank you. You too. Sorry, ladies. It was coming to empty my trash and they locked the door. So just know, but if you took a picture of this, maybe to just kind of put it in your memory bank, or you could just write it, prone, laying face down, supine, laying face up. Lateral means side. So rather you've been told right, left side, just know that lateral means side. Okay. I did want to show you that. Do I have any questions regarding the positions? Okay. Let me go ahead and get our special collections. It's a little under 9 minutes. It's 8:51 as far as the length of this video. Let me go ahead and get it together. Y'all let me know if y'all have any questions, or let me know when I end the class if you have any questions to stay on. It's no problem. Okay.
Welcome to another PowerPoint presentation by Phlebotomy Solutions. In this PowerPoint presentation, we'll be looking at special blood collection procedures. Let's begin with bilirubin. What is bilirubin? Bilirubin is described as a yellow-orange substance, which results from the breakdown of hemoglobin. Now, bilirubin is a waste product from the breakdown of old red blood cells, which is processed by the liver for removal from the body. Abnormally high bilirubin levels are often indicative of liver disease. The result is jaundice, yellow skin, and yellow in the white of the eyes. Now, what would be the purpose of this test? Well, one we will be determining liver disease. Another would determine blockage in the bile duct. And another is neonatal jaundice. And again, all these are all associated with issues with the liver. And some of the precautions we need to take when drawing this type of blood sample or checking for high bilirubin levels, we need to minimize exposure to light. That is referring to the blood sample itself. When we are done collecting the blood, we need to minimize exposure to the light. This is a sensitive test, and we need to make sure that we keep it light exposure to the bare minimum. And by doing so, we might be using some light blocking amber colored containers. Or if we don't have that, we can use aluminum foil to wrap around the tube immediately to prevent the minimum exposure to light. Now let's talk about the glucose tolerance test, which we test for high or low sugar in the body. And the administration of glucose is to determine how quickly it is cleared from the blood. Now the reasons, or some of the reasons for the test being ordered, is one, to check for glucose levels, checking for diabetes, insulin resistance, and a basic insulin overview of typically glucogen. Now, the test is usually used to test for diabetes and the things listed, and the glucose is most often given orally, so the common test is technically an oral glucose tolerance test, or an OGTT. And the test may be performed as part of a panel test, such as a comprehensive metabolic panel. And again, we evaluate body's ability to metabolize the glucose or the sugar. Now that is referred to usually typically as hyperglycemia or hypoglycemia. And hyper is the high and the hypo is the low. Think of it this way. When you give your children a lot of sugar, they become, we say, hyperactive. Well, hyper is high. So hyperglycemia is high sugar, while the hypo is low sugar. And if you can see, sometimes it requires certain things like no food or drinks for 8 to 12 hours prior to the test. And then they drink the glucose, and the blood is tested 2 hours later. And of course, high glucose levels is potential for diabetes. So again, this is the glucose tolerance test. Now let's talk about the preparation and procedures. One is balanced meals. Now the doctor might request the patient to have a certain meal time cutoff, let's say nothing after 8 o'clock. And before that, maybe a balanced meal of certain types of foods to eat that they want the patient to do before they cut off the meal, or even afterward, what they can and cannot eat afterward. And typically, the water intake is also mentioned, that they might have a little bit of water or none. Now, typically, they're able to drink just a little bit or sips of water that will not harm the test at all if they're on an 8 to 12 hour fast. So water is usually typically good, just not cups of water, but sipping water is okay. Also, this might require an 8 or 12 hour fast, depends what the doctor's ordered. So again, follow the physician's protocol on preparation and procedures. And again, we want to make sure that there's no eating, there's also no smoking, no gum chewing, or caffeine of any kind, etc. If they're in an 8 to 12 hour fast, this is important because again, this can change the results of the test. And of course, we draw the blood 2 hours after they drink the cola or the glucose cola you see on the screen. And typically it can be done also in intervals as well. And the other important thing is knowing when to stop the test. Now, typically we don't, as phlebotomists, stop any test. We need to get typically a doctor's permission to go ahead and cancel any tests that we've done. Now, this might happen because after the patient has drinking the cola, they might get nauseous and even throw up, or feel sick to the stomach, and this might cause us to have to stop and put the test for a future date. But again, we need to contact the doctor and let them know the situation. Or after they drink the cola, they eat something or do something they're not supposed to do, that could also cause the test to be stopped and done for a future date. But again, we must also typically consult the physician, let them know that there's a problem with the test, and he will give the final say if we should stop the test, or he might want to continue and take the blood test anyway. So always consult the physician before canceling or stopping any glucose test. Now let's talk about blood cultures and why a doctor will order blood cultures. One reason is to check for septicemia. If a patient comes in with the symptoms of fever, chills, or tachycardia, the doctor will order blood cultures to determine if there is a bacterial infection that's circulating through the blood throughout the body. Now, if there's no symptoms, but the doctor suspects that there might be a bacterial infection, the doctor will check for bacteremia. And again, we might also check for an antibiotic sensitivity on the patients. This is what is used typically for blood cultures. Now, in doing so, we use 2 blood culture bottles, an aerobic and anaerobic. And typically these are timed tests. We might have to go back for a second set. So what you would do is you'd go in with the 2 bottles of aerobic and anaerobic and draw from a particular venipuncture site, and then come back 15-20 minutes later to collect another set from a different venipuncture site altogether. You will never draw from the same venipuncture site you did for the first initial blood cultures. And if you're drawing a neonate or an infant, you will use an aerobic bottle only. Unless the doctor suspects an anaerobic infection, you will use an aerobic bottle, and that usually comes with a pink top instead of a lavender or a red. And when you prep the site, you will use a ChloraPrep wipe, not an alcohol prep pad. A ChloraPrep wipe is used, and after you do that, you will never repalpate the site. And again, no repalpating after you use the ChloraPrep wipe for a blood culture collection. Now let's talk about therapeutic drug monitoring. Evaluate and manage medication therapy. Now, this is determined if the medication that the patient is on is too weak or too toxic for the patient. And also we do types of blood level checks, which is usually a trough level, when the drug level in blood is collected when the lowest serum concentration is expected. That is usually just before the next dose. And also peak levels, and this is usually 15 to 30 minutes after the medication has been given. The highest level of drug is expected at that time. Now let's talk about toxicology screening. This can be done with blood or urine, and we would measure legal and illegal substances through blood or urine. And of course, we have to make sure we take right preparations to do so. We need to get consent from the patient. Now this can come also from a court order if the patient is suspected of something of an illegal activity, DUI, or some kind of accident that the police officer might have suspected the patient to be on some kind of drugs. We need a court order consent. We also need a chain of custody, and the said chain of custody form is added onto as the test specimen travels from person to person. That gives complete accountability of a test sample, as well as a list of medications. So when you also need a list of medications the patient might be on to determine outside of the legal or illegal substances and be able to measure that out. Thank you, and this is the end of Special Blood Collection Procedures brought to you by phlebotomysolutions.org.
Give me one moment. I want to back on up a little bit. Does anybody have any questions at this moment? Give me a second. I want to reiterate some things, you know how I do. The first slide talked about bilirubin. Again, we're not in nursing school. It's not anything of big magnitude. Can y'all hear me? It looks like I'm froze. Oh, there I go. The first slide talked about bilirubin. Again, we're not in nursing school, so I don't want to overload you or overwhelm you with any of the big information. But bilirubin does have to do with a person's liver. So if a doctor does order a bilirubin level, you just know what you need to do. You look at your requisition, get accustomed to what color tube it go in. Some of us who've had children or been through anything with a baby having jaundice, basically their bilirubin levels were off as a baby, and it does have to do with liver, but as a baby, they're put under this special light to correct the jaundice, okay, to correct the bilirubin. But what is so crazy is that if you're going to draw a bilirubin level on anyone, of a child, adult, you see where it says minimize exposure to light, right? So as a baby, they're put under the light to correct it because it penetrates through their skin. But if we were to draw blood and we put it in the blood tube, when we package it, it cannot be, it's too sensitive to light. So we have to protect it from light. So on our special collections segment, the first thing that they talk about is bilirubin. So if you were to draw bilirubin, you know now that it needs to be protected from light. And it's protected from light. It does say, you know, most people can protect it by wrapping it up in aluminum foil, but that's kind of more of olden days. But now they have amber colored lab bags. So give me a second. I actually don't have any amber color. I may have to figure out how I can get those. But you know, our regular lab bags, right, which is clear, that's what we put our labs in. Well, if we need to draw a bilirubin, the bag will be a type of clear, but it'll be an amber clear, okay? Not orange like this, but it'll be kind of like a pink red color. That is a type of tint that protects the specimen, the blood specimen, from light. So what do you need to know? If you draw a bilirubin, that is a blood test that needs to be protected from light. Will you see it again? 1,000 times. Okay, so know that a bilirubin level needs to be, if you draw a bilirubin, it needs to be protected from light, okay? Bilirubin. But just as a background, you just know that the reason why the doctor is drawing a bilirubin, because something is wrong with the patient's liver, so to speak. But bilirubin needs to be withheld and protected from light, okay? Bilirubin protected from light. Now, on another special collections test, I know that we are phlebotomists, but this is also a part of blood drawing. What this is that you may have someone that comes in to your lab that's pregnant and the doctor ordered this particular test. You can see at the top, it's called glucose tolerance test. We know that glucose is another name of sugar, okay? So what it is that it's not only for pregnant women. It could be for older people too, you know, medium age, middle age people. It doesn't matter. But anyone can get this particular test that says glucose tolerance test. What it is that the doctor wants you to drink all of this sugar. Let me fast forward so you can look at the bottles. The doctor wants you to drink this one bottle of straight sugar. And it's called a glucose tolerance test because the doctor's trying to see how well your body can tolerate all this sugar, okay? So in pregnant women, some women have just diabetes while they're pregnant, and this is how it's determined. Oh, okay, thank you, Ashley. I'm gonna have to find some more. Now, these bottles are considered the glucose tolerance test, and the phlebotomist will make you drink the whole thing. Once you drink the whole thing, then you have to sit for 1 hour or 2 hours or 3 hours. It depends on what the doctor say. It will be on the doctor order. Okay, so you would drink the sugary drink, and then the doctor may say, okay, I want to see how her body took that after 2 hours of drinking it. So literally you will wait in the lab for 2 hours. It's a process. And then the technician, the lab, that you as the phlebotomist would know, okay, Ms. Chopin, you know, we clocked her time. We start the timer, you know, it's 10 o'clock now, it's 12 o'clock. So you call me to the back with the proper procedures of how to identify me. And then you draw my blood and it goes to the doctor. Okay. So that's what that means. But before the blood is drawn, these are one of those tests that you have to be fasting. Nothing to eat or drink within 8 to 12 hours, okay? So these are one of those tests that the patient has to be fasting. If they ate a banana, if they drunk some coffee, you're not going to be able to proceed with this test. Do not give them the sugary drink if you know that they are not fasting, okay? So the reason that this test is ordered, like I said, is for glucose, which is sugar, and that is basically checking for diabetes. It's trying to see how resistant, if your body even have enough insulin to fight off all that sugar. Our body has insulin. Some of our bodies is lacking insulin, and that's where the persons with diabetes come in at. The body doesn't have enough insulin to bring the sugar down. So the doctor tests you by having you drink all this sugar, and the special collection part of it is you need to be fasting. You need to drink that drink, and the special collection is the timed part of it. If the doctor say, okay, draw her blood 1 hour, draw her blood again after a complete 2 hours. So it may be multiple venipunctures that you have to do according to the doctor. Okay, so it's all about a glucose tolerance test. So just know that for a glucose tolerance test, your patient needs to be fasting. And it also mentioned about, some people don't realize, chewing gum, smoking can be a little bit of problems, because all of that stuff is penetrated into our like saliva, and we're swallowing it. So, some gum have sugar, some, have caffeine, smoking, nicotine. So we do want to ask those questions when it comes to a test like this. Okay. Do I have any questions regarding a glucose tolerance test? The doctor is testing how well a person's body can tolerate the sugar. Our part as a phlebotomist is making sure they were fasting and following the doctor's orders to know after they drunk the drink, when are we supposed to draw their blood? An hour, 2 hours, 3 hours after, so that's the special collection. Okay. Most of the time, the most average is 2 hours after they drunk the drink, then they come back and get their blood drawn. Some doctors say, okay, draw her blood 2 hours after she drunk the drink, and then she can go eat. But then I want her blood to be drawn 2 hours after she eats. So that's something that you would get accustomed to. It would be something that your facility would train you on, because it is a special collection, but you do need to be introduced to it. And you will see a couple of questions about glucose tolerance tests on your national exam. Everything that you need to be familiar with about it is in this video, what I just went over. Okay, simple. Fasting, they need to be fasting, nothing to eat, to drink by mouth. They need to be fasting 8 to 12 hours. Okay, and they drink this sugary drink, and then you need to know when to draw their blood after they finish drinking the drink, which is typically 2 hours. And the video also mentioned when to stop. You can't just not draw the patient's blood when it comes to this test. If something happens, or the patient refuses, or the patient drinks the drink and then throw up and like, oh my God, I just can't take it. I'm 8 months pregnant and I can't do it no more. Well, you guys need to go ahead and tell your supervisor, and then the supervisor may tell you, okay, call the doctor's office and let the doctor know, and let him or her know what we need to do to proceed. So these are one of those tests that you can't just stop, okay? But if you feel like, using your judgment, then you have to call a doctor. The only one that can tell you don't move forward is the doctor. Even if the patient is refusing and fighting you, call the doctor and let them know. And 9 times out of 10, 10 times out of 10, the doctor is going to say, okay, we just have to try this another time. But you need to get the doctor's approval, that the reason why you wasn't able to complete the glucose tolerance test. All right, so it talked about blood cultures. What we know so far about blood cultures is that the doctor has a feeling that the patient has a bacteria of some sort, or even septicemia. These two reasons will be why blood culture it needs to be done. You will see this on your national exam. It will probably say, for what reason would the doctor need blood cultures? It will either say septicemia or bacteremia. One of those is your answer, okay? You will be able to know that. So we also know with blood cultures, it's always going to be 2. So if the doctor say I need blood cultures times 1, it's really 1 stick, but both bottles. If the doctor say I need blood cultures times 2, an hour apart, then that means that you take these 2 bottles, you stick me from whatever is good for you in one site, and then you come back in another hour or 2 with two new bottles. You stick me in another site, whether it's my hand or the opposite arm, and you stick me and you draw those 2 bottles. It's a such thing. Just know that one collection is always 2 bottles at a time, unless you working and you're drawing with babies. They only have 1 bottle. Okay. And this is going to the microbiology lab to check for what the bacteria name is. And when it says antibiotic sensitivity, that means that it's coming back with a list of antibiotics that works best for me, works best for you. Now, last but not least, when we talk about special collections, therapeutic drug monitoring. You can be put on any type of antibiotics like vancomycin, or you could be a mental patient. I hate to say it that way, but you could be a behavioral health patient and you have mental challenges and you go see your psychiatrist. Your psychiatrist puts you on lithium or some other things. There are some drugs out there that the doctor can't just prescribe you and let you be for months. The doctor actually have to make sure that it's working for you. So they do have to do therapeutic drug monitoring to see if the medication is too weak for you or if it's too toxic. And we know now that toxic means too much, right? So with that being said, that is considered a special collection. So if you are a phlebotomist in the hospital, you would get an order that says that the doctor has ordered a peak level or a, where did it go? Oh, here it is. I guess I didn't go. That the doctor ordered, okay, here it is, right underneath there. It's 2 things, peak and trough and peak. Trough is gonna be first, you guys. When you make your notes, if you need to make your notes for therapeutic drug monitoring, then do so. Therapeutic drug monitoring comes in 2 ways. The doctor is going to tell you as a phlebotomist to draw the blood before the medication was given and then after the medication was given. Trough is before the medication was given. Peak is after the medication was given. The doctor want to see at its peakest level, how is the medication working? You're going to draw the blood, results going to come in, it's going to be a number, and it's the doctor's responsibility to know, oh, okay, well, we're in the therapeutic range versus it being too weak or too much. If it's too weak, the doctor knows to bring up the dosage. If it's too much, the doctor knows to bring the dosage down. But he or she probably will still have you doing these levels before they're discharged from the hospital, because most doctors, I hope, won't discharge us from the hospital knowing that we a little bit off with our drug levels. So what you need to know about therapeutic drug levels, that there is a purpose, that it could be too weak or too much. Trough is before, peak is after. Okay? I don't care if the instructions is, while I'm in the hospital, I'm supposed to take this medication in the morning and the night. Before I take my first dose, the doctor may say, okay, we need a trough before Winetta take her first dose. Then you coordinate with the nurse, like, okay, Nurse Chris, I got an order for what Miss Chopin in room 303. It says that she need a trough level before her first dose. When is her first dose? So as the nurse, Chris will say, oh, it's at 8 a.m., you know, so that means that as a phlebotomist, I know that I need to go down there, you know, before the nurse gives the medicine and draw the blood for the trough. Secondly, the orders may say after the fourth dose, then I want a peak level. That's probably what the doctor is saying. So with that being said, you know that I take the medicine twice a day, morning, night. So one, first dose, second dose. The next day, the first dose of this day is the third dose, and the evening dose is the fourth dose. So whoever's the phlebotomist working my room in 303, they would come and do my peak level after the nurse gave me my medication for that night, if that makes sense. What you need to know is trough is before, peak is after. This is considered a special collections because you have to work hand in hand with the nurse to know when the medication is supposed to be given, when it was given, so you can draw the blood after, you know, and all of that. So that's why it's a special collection. And it's called therapeutic drug monitoring, okay? Any questions with that? I know that that's a little bit in detail, but it is. Now, we're getting to the end of our day. So when we meet on Saturday, I'm going to finish this toxicology because this chain of custody, what you see here, you're going to need to know what that is. It's not a big segment at all. I could take about 5 minutes to explain in detail what that means, but it's a part of toxicology screening, meaning that the patient has too much of something, too much of drugs, too much of alcohol, you know, and of different things. So I'm going to continue that on Saturday, right before we get started with what I have on our agenda for Saturday. And then I'm going to do finish the processing and transporting because I still want to talk about other blood works that need to be put on ice, okay? And then I'm gonna briefly go over blood banking with the blood types so you guys can know, for those of you that may work want to work in the blood bank. You need to know. It don't take me a lot of time to explain in detail so you can know, okay? And then we'll finish everything else on the agenda in person, which make sure everyone is dehydrated. Drink your water the night before and the morning of. Be ready because we will continue our live sticks. I know that we had Miss Chris and Zanab did some live sticks that day, but we're going to continue to do our live sticks. And I will have 2 of my previous students join us so we can actually have more, you know, as far as the practice is concerned. I will have room. I will use the middle room with nothing in there so we can have space. So come hydrated. Just like before, I will have, you know, snacks for you, you know, in case, you know, you do get hungry because Saturday is a long day. Anything in between time, just let me know. I'll see you at Saturday at 10. Remember, I'll send you another quiz, if not tonight by morning. The way that my track record has been going, I've been sending it the next day. So just know I will send another quiz and it's due tomorrow by midnight. You guys are doing so well. I guess I'm explaining it to, you know, I'm explaining it well, hopefully, and then I've given you the material that I know that you need. So let's continue that on. Keep everything in mind. Don't take the questions that I give you on the quiz lightly. Those are for a reason, okay? So just keep that in mind. But other than that, I appreciate you ladies. I will see you all on Saturday. Just let me know if you have any questions, okay? Good night. See y'all Saturday. Miss Ashley, do you have a question for me?
Okay, hello.
Uh-huh.
So I know I am not in the class, but I have been working on stuff at home. I don't, can you see me?
I can't see you actually. I can't. It's like a dark screen.
It says every time I try to turn my camera on, it won't let me
Is the camera like closed? Oh, let me stop the recording.